All right, we are nearing 12:05, so we'll go ahead and get started. And welcome everyone, and a special welcome to some of our nephrology colleagues who are joining us for this uh, talk that is relevant to multidisciplines. We are welcoming today Julio Lamprea Montealegre, who will be talking to us about linking paths, and his talk titled Linking Paths Enhancing Cardiovascular Health Through Early CKD Detection and Treatment. So for a little bit of an introduction, Dr. Julio Lamprea Montealegre is a cardiologist who focuses on preventive cardiology. He is originally from Colombia, where he earned his medical degree from Javeriana University School of Medicine. Based on his interest in public health and evidence-based medicine, he then came to the United States, where he earned a MPH at the Johns Hopkins Bloomberg School of Public Health in Baltimore, and then continued on for a PhD in cardiovascular epidemiology. Dr. Lamprea Montealegre subsequently completed his internal medicine residency at the University of Maryland Medical Center in Baltimore, his clinical cardiology fellowship at the University of Washington Medical Center, and a postdoctoral research fellowship at UW as well. His clinical interests include preventive cardiology and cardiovascular risk assessment, cardiorenal syndrome, dyslipidemias, heart valve disease, and echocardiography. His research focuses on cardiovascular health consequences of chronic kidney disease, and current projects aim to prevent cardiovascular disease through the early detection and treatment of CKD. So with that, Dr. Lamprea Montealegre, I'll let you take it away.
Thank you, James. I'm very glad to be here. So what I want to do in these 40 or 50 minutes is to, in a way, try to convince you of how important it is to detect and treat CKD for cardiovascular health. Some of the medications that I'm going to talk about, like SGLT2 inhibitors, you're all familiar with those medications for heart failure, but my perspective today is primary cardiovascular prevention. These are my disclosures. I have a Career Development Award and NHLBI K99 R00, and the center that I'm affiliated with, the KHRC here at UCSF, has a research agreement with Bayer. Bayer produces finerenone, which is one of the medications that I will talk about today. One of the reasons that I think this is so important is because it's a major global health problem, CKD. We define CKD as a GFR less than 60 or an albumin to creatinine ratio of greater than 30, and those have to be persistent for at least 90 days. It is super common, so 10 to 15% of adults in the US have chronic kidney disease, and it is of course much more common in people with hypertension and diabetes, because those two are the main reasons why someone would have chronic kidney disease. CKD is projected to become the 5th leading cause of death worldwide by 2030. And if you take into account that the major reasons, the major causes of CKD are hypertension and diabetes, and then that the major consequence of having CKD is premature cardiovascular disease, then you have a very large cardio-kidney metabolic epidemic, which I'll highlight today. So I wanted to start by highlighting how important CKD is as a pure marker of cardiovascular risk. By that, I mean people with high-risk CKD have to be identified because the risk of cardiovascular disease is so high that we need to identify these people and treat them accordingly. That means get their blood pressure under control, get their cholesterol under control. So to exemplify this is a KDIGO cardiorenal risk classification. KDIGO is an international organization that gathers experts in kidney disease from around the world and issues CKD care guidelines. This is not just staging system, which is based on albuminuria and GFR, but it's also a cardiorenal risk classification. So I think we can all agree that if you go down on the GFR gets very, very low, or you're near dialysis, your risk of cardiovascular disease is so high. In fact, by the time you get there, most people would have some sort of cardiovascular disease. So for primary cardiovascular prevention, is useful to focus on higher GFR stages, but you would still have a high risk. But most people would not have symptoms of CKD, and most people would not have established cardiovascular disease. So I wanted to focus on two groups here with GFR greater than 45. Again, this will be largely asymptomatic person. So high GFR, but significant albuminuria. So let's look at the risk profile of these two groups here. So the first group will have a eGFR that's normal, greater than 60, high albuminuria and ACR greater than 30. And these people would have a 4-fold higher risk of CVD death, 67-fold higher risk of end-stage kidney disease. But if you translate that into absolute estimates, the CVD mortality of this group at 10 years would be close to 20%, which is extremely high, and around 3% of progressing to end-stage kidney disease. The second group, which is similar, but just slightly lower GFR, would have similar relative risks, but the absolute risk would just you start seeing more end-stage kidney disease. And that happens as you get closer to 15 or 20 as the GFR drops, the absolute risk of progressing to end-stage kidney disease increases. So what this means is that taking into account that KDIGO risk classification, the cardiorenal risk of CKD is not uniform. So when you identify people with CKD, it's not useful to say someone has CKD or not. It's useful to risk stratify these patients using both albuminuria and GFR. The other point I wanted to make is that when you have a high risk or very high risk CKD person, global CVD predictive equations are not useful. You already have a very high risk person, so you have to treat them accordingly. And the third point is that the cardiorenal risk of CKD is largely driven by CVD events. For an average patient with CKD, for every 100 cardiorenal complications associated with CKD, about 90 of those complications will be cardiovascular. Now, the KDIGO, there was a new development in that KDIGO classification that was created in 2012. There was a recent paper that they published in JAMA, adding more people. I didn't say that the way they came up with that cardiorenal classification is by pulling hundreds and thousands of people with CKD from population-based cohorts, but also from administrative data. So there's a new iteration of the KDIGO risk classification recently published, and this time they also looked at cardiovascular mortality, but they looked at single cardiovascular events. As it turns out, CKD is predictive of every single cardiovascular event that you can imagine. So it's just an exceptionally good marker of cardiovascular risk. What these graphs show on the left is GFR estimated by creatinine. The graph on the right is GFR estimated by creatinine cystatin C. It looks more linear just because cystatin C is a better marker of cardiovascular risk than creatinine is, and that is mainly because it's more unconfounded, if you will, than creatinine. At UCSF, we have now cystatin C that's widely available. Now, criticism that I hear about, screening people for CKD and staging them is, why would you do that if you already have, if most of these patients would have diabetes or most of these patients have hypertension? So they're already high risk. So why would you label someone with CKD? And I think that criticism is a little bit misguided because, risk in diabetes or hypertension is not uniform. So one way to look at this is kind of ask the question of why do people with diabetes have a premature mortality? Looking at, in a way, the excess risk in type 2 diabetes. And the graph on the left, this study tried to get at that. They used NHANES. NHANES is this national survey of adults, which is representative of the US population. And they compared people without diabetes to people with diabetes. And they asked the question, why do people with type 2 diabetes die from? what they found that compared to people without diabetes, which is the dashed line, the excess risk and the y-axis is cumulative incidence of mortality at 10 years, the large majority of these patients would have CKD. In fact, around 90% of the excess cardiovascular risk in type 2 diabetes concentrates in people with CKD. It follows that if you were only to target people with CKD, with diabetes that have CKD, you would be preventing the vast majority of complications associated with type 2 diabetes. On the right is a table, and this is a different study, but they ask a similar question. This is a Swedish observational study. They enrolled 400,000 adults with type 2 diabetes in Sweden. It turns out that that's 90% of the total population in Sweden with type 2 diabetes. They compare them to the general population, and the one predictor that was independently associated with premature mortality was one, GFR, when you adjust it for multiple other factors. These estimates are hazard ratios and 95% confidence interval, and albuminuria. And there was a graded dose response association between both GFR and albuminuria and CVD mortality. What this means is that if we only focus on people with CKD, or people with type 2 diabetes, and this also applies for hypertension, these are the people that will go on and get cardiovascular complications. Now, what do we do with that data? So the guidelines have responded accordingly, and the KDIGO blood pressure guidelines, as most other blood pressure guidelines around the world, they recommend to target a systolic blood pressure of less than 120 in adults with CKD, and that's largely informed by the SPRINT trial. The European Society of Cardiology lipid guidelines, they took it one step farther, and I recommend for anyone that's interested in preventive cardiology to read that document because it's a good sort of epidemiology document. But what they did is they put CKD at the center of cardiovascular prevention. And what they recommend is that if you have a person that has that sort of KDIGO high risk or very high risk stage, you should aim to get the cholesterol down to very low targets, to less than 55 milligrams per deciliter. That's the same recommendation that they give for people with established cardiovascular disease. And the reason for that is the risk is the same. Now, in contrast to that, the ACC/AHA, BP, blood pressure, and lipid guidelines, we do not emphasize CKD too much. And I think a problem, in my opinion, with those guidelines is the over-reliance on global cardiovascular risk equations like the ASCVD pooled cohort equation. They do mention CKD as a risk enhancer, but I always have trouble following what that means when you're already conditioning on a risk equation. So that's sort of CKD as a cardiovascular risk marker. But I think the importance of CKD is not just that, it's also that CKD is a target for treatment. So this gets more as a causal effect of CKD on cardiovascular health. And the biological plausibility that preserving kidney function will favorably impact the heart is very high. And just because virtually every physiologic pathway that when it gets deranged would cause cardiovascular disease would also cause kidney disease. Even for, seemingly unrelated pathways like mineral metabolism, when you have CKD and that pathway gets altered, you have people developing severe vascular calcification, which is what we see in people with very advanced CKD or end-stage kidney disease. We tend to see that medial calcification that pathologists, I believe, used to call Montever's calcification. So a lot of overlap in terms of mechanisms of disease between the kidney and the heart. The development of medications to treat CKD is interesting, I think. because starting in 1993, for more than 20 years, we only had one class of medications, which is the ACE inhibitors and the angiotensin receptor blockers. And it's not that I'm minimizing this medication class. In fact, most of the contemporary trials that I'm going to talk about in a second have been done on a background of maximal doses of ACEs and ARBs. So they continue to be the backbone of CKD treatment, but it was just that class of medication. So in 2008, the FDA released new recommendations for new medications for diabetes. And what they require is that for any new class of medication, they had to show that they were safe from a cardiovascular standpoint. So following that recommendation, EMPA-REG and LEADER came in 2015, and they not just showed that they were safe from a cardiovascular perspective, but they showed a very strong signal of cardiovascular and kidney protection. And so that was the impetus for 3 trials of SGLT2 inhibitors that followed EMPA-REG. And these were done in people with type 2 diabetes, with and without CKD. Credence, DAPA-CKD, and EMPA-KIDNEY, looking at the effect of SGLT2 inhibitors on cardiorenal outcomes in people with CKD. All of these 3 trials were stopped early because of efficacy. Then you have a non-steroidal MRA, and there were 2 trials done in people with kidney disease looking at the effect of finerenone on cardiovascular and kidney outcomes. These 2 trials, just like with the SGLT2 inhibitors, were stopped early because of efficacy. And the last sort of medication in the saga is the GLP-1 receptor agonist, semaglutide. And the FLOW trial was just recently announced in December 2023 that it was stopped again early because of efficacy. So in the span of just 10 years, we now have many more options to treat these patients with CKD, so I'll expand on that. So starting with people with, with the SGLT2 inhibitors, meta-analysis of randomized clinical trials have consistently shown around a 50% relative risk reduction in cardiovascular mortality, around 30% in hospitalizations for heart failure, and around 40% relative risk reduction in the risk of progressing to CKD progression. And that's mainly driven from progression to dialysis, so very hard outcomes. And then in terms of the mechanisms of why do SGLT2 inhibitors protect the kidneys, there's still many hypotheses, but the one effect that we know exists is that the hemodynamic effect of these medications, they lower intraglomerular pressures and they protect the kidneys that way. I can expand on that if we can later, but that's what the one mechanism that we know it's clear for SGLT2 inhibitors. So expanding on each of these SGLT2 trials, Credence was the first SGLT2 trial that was devoted to look at people with CKD. But all these patients had type 2 diabetes. And there were, if you look back at this KDIGO risk classification, all high or very high risk patients, but with high GFRs. GFRs greater than 30, but severe albuminuria. So kind of very similar to the group that I showed you early on. The results of Credence were very strong. The trials were stopped early at around 2.5 years, a median time of 2.5 years because of efficacy. The primary composite endpoint was progression to end-stage kidney disease, doubling of creatinine, or CVD renal death. And what they found was a 30% relative risk reduction in the composite outcome. Secondary outcome was death from a cardiovascular cause. This was also a positive outcome. There was a 20% relative risk reduction in CVD mortality. If you take into account that this is very high risk population, that 20% relative risk reduction translate in large absolute benefits. Something that I find interesting is just to emphasize how high of a risk CKD is for cardiovascular disease, is that if you look at the cumulative incidence of CVD death at 3.5 years is 8%. So that means that at 10 years, around 23-24% of people would have died from cardiovascular disease. Again, these are largely a population without established cardiovascular disease. This is a population with an eGFR higher than 30. They would not have symptoms of cardiovascular, of kidney disease, and they would not have, by the majority, would not have established cardiovascular disease. So I just want to emphasize how important this is for primary cardiovascular prevention. So after Credence came DAPA-CKD, and DAPA-CKD enrolled a similar patient profile in terms of risk, but then they enrolled people with and without type 2 diabetes. The median albuminuria in this population was 949. So high risk based on albuminuria, but not high risk based on GFR. And what they found was similar effects compared to Credence. The primary endpoint was a composite of declined GFR, more than 50%, end-stage kidney disease, or a renal or CVD death. The relative risk reduction was close to 40% in those outcomes. And then the secondary outcome of CVD death or hospitalization for heart failure, there was around a 30% relative risk reduction with dapagliflozin. There was no evidence of interaction by type 2 diabetes, meaning they worked equally well in people with and without type 2 diabetes. And then after DAPA-CKD, the last sort of trial in this space was EMPA-KIDNEY. And EMPA-KIDNEY was an interesting study. Like DAPA-CKD, they enrolled patients with and without type 2 diabetes. They had a group that looked like Credence and like DAPA-CKD with high albuminuria, but they also enrolled a group of people with just low GFR without albumin. So they were able to pre-specify the outcome of cardiovascular events looking at interaction by albuminuria. This was a positive trial. They stopped it early because they met for efficacy in the composite outcome of progression of CKD or CVD death. But what I find more interesting about this trial is that they were able to assess this effect modification on the benefit of empagliflozin. What they found was there was not significant difference by the presence or absence of diabetes. There was no significant difference by GFR, but there was evidence of effect modification by albuminuria, meaning people that had high albuminuria not only had higher absolute number of events, but it seemed that the effect was stronger in people with albuminuria compared to those without. So in addition to the SGLT2 inhibitors, we have this new medication, non-steroidal MRA called finerenone. And by non-steroidal, we think it is probably safer in terms, has probably less side effect profiles just by being a non-steroidal medication compared to steroidal MRAs like aldactone. And the trials that I'm going to discuss, the meta-analysis of those trials have shown that they reduce CVD mortality by around 22%. They reduce hospitalizations for heart failure by around 22%. And then they reduce the relative risk of CKD progression, largely to dialysis, by around 23%. Figaro was the first non-steroidal MRA trial. And in Figaro, they enrolled patients with type 2 diabetes and high-risk CKD, similar to the ones in Credence and DAPA-CKD. Although the albuminuria was a little bit lower, the median albuminuria in this trial was 308 milligrams per gram. And what they found was around a 13% relative risk reduction in the composite outcome of CVD death, stroke, MI, hospitalization for heart failure. That composite endpoint was largely driven by the reduction in the incidence of a hospitalization for heart failure. By design, at enrollment, there could not be patients at baseline with a diagnosis of clinical heart failure. So these were people with unknown heart failure at baseline. And this is an MRA, hyperkalemia that they defined by a potassium concentration of higher than 5 milliequivalents per liter was common, 10% versus 5.3% with placebo. That hyperkalemia resulted in discontinuation of the medication in around 1.2% of the participants. So a significantly positive trial, less so when you compare them to the SGLT2 trials. It's been claimed that finerenone is safer and is also more effective than aldactone, but to my knowledge, we do not have any trial that has compared, aldactone versus finerenone head to head. So I think that needs to be done in this space. And then the last one in this sort of saga of positive trials was the incretin GLP-1 receptor agonist semaglutide. I do not have the numbers for this trial because it was just recently announced that it was stopped early because of efficacy. That's the FLOW trial. I believe that's going to be presented in ACC, if I'm not mistaken, later this year. But one thing that it's interesting about these medications is that I tend to view them as different than finerenone or SGLT2 inhibitors, not as a hemodynamic type of medication. So it would be very interesting to me to know what drives the protection, the kidney protection in this population. Is it the metabolic effects that we all know of semaglutide, of improving glycemic control, reducing weight, or are there any kidney-specific factors that may be protected? So we'll know more in the future. There is a new trial of Mounjaro. Mounjaro is a GLP-1 receptor agonist and a GIP that's called tirzepatide that's currently ongoing. And there's another trial that's looking at the effect of the combination of an SGLT2 inhibitor with finerenone compared to either a single SGLT2 inhibitor or finerenone. And that I think is greatly needed to look at the effect to see if there's any additive effects of an SGLT2 inhibitor plus finerenone on cardiorenal outcomes. So all those positive trials led the American Diabetes Association to kind of revamp completely the guidelines for type 2 diabetes. So in 2019, they developed new guidelines that basically recommended to think about two things when you have a patient with type 2 diabetes. One is glycemic control, but something completely dependent is cardiorenal risk reduction. And for that, what they recommend is you have a patient with type 2 diabetes and CKD, you have to ask the question, is the patient on a maximal tolerated dose of an ACE or an R? If not, that patient should be on a maximally tolerated dose of an ACE or an R. Then you should add an SGLT2 inhibitor. And if the patient has remaining albuminuria on those two medications, you should add finerenone. So this is super interesting because to me, it sounds much like GGMT that we deal in heart failure. But remember, this is patients largely asymptomatic, and this will be largely for primary cardiorenal protection. So that leads me to a new topic, which is the AHA kind of finally caught up with this evidence, and then they released in December 2023 these new guidelines of cardiokidney metabolic health syndrome. And This was recently published in Circulation, and what they define is the CKM syndrome as a health disorder that's attributable to the connections between obesity, diabetes, chronic kidney disease, and cardiovascular disease. And one of the things that I found very useful from this new set of guidelines is that they created this staging system that reflects the spectrum of risk and opportunities for prevention at each point in time in this staging system. But from a CKD perspective, I was glad to see that they finally put CKD at the center of cardiovascular protection. In this stage 2, they recommend that every single patient with hypertension and diabetes gets tested and risk stratified with GFR and albuminuria for CKD. And they went one step ahead and they defined the subclinical cardiovascular stage, largely in patients that have coronary calcium that's positive or subclinical heart failure. But what they said is if you have a patient with high or very high risk CKD, the risk of these patients will be equivalent to having subclinical cardiovascular disease. I was also glad to see that they expanded the outcomes and they, for the first time, including heart failure endpoints in the new risk equations that I will talk about. And they included atrial fibrillation, which is so common in these patients that have obesity, diabetes, and chronic kidney disease. So a very nice development by the AHA for sure. So there are sort of many new welcome developments, as I said, of these guidelines. As I mentioned, they put CKD at the center of CVD prevention. That was a much needed development. They called for this integrated collaborative approach between cardiologists, nephrologists, endocrinologists, centered around primary care. And they came up with new risk equations that are aimed to replace the ASCVD full cohort equations. They include new risk factors in those set of equations, like GFR, albuminuria, NYC. They changed the spectrum of timeline of cardiovascular endpoints. So they expanded the endpoint to a 30-year risk estimate. They include a zip code trying to get at social determinants of health. And as I mentioned, they include both ASCVD and heart failure outcomes. So very important document, very important new development in prevention. But one thing that I want to mention is that when they call for this integrated approach to care, which I agree with them, that's how we should practice, it is more aspirational than what actually happens because we just don't practice medicine that way. There are really not integrated models of preventive care. Not even integrated health systems like the VA or Kaiser, we practice that way. So it's largely aspirational, and that means there's going to be a lot of work to do in this space. And the other point is the recommendations for treatment largely overlap with the American Diabetes Association guidelines. And as I mentioned, these guidelines, it really sounds like GGMT, and implementation of GGMT in asymptomatic population is going to be very difficult. And if you look into these guidelines, they call in for testing for albuminuria in basically everyone, not only for testing, but following up on albuminuria to see if you need to add medication. So a lot of new recommendations. And when that happens, you know right from the start that implementation is going to be very difficult. It's going to be necessary because I fully believe that implementing these guidelines is going to prevent a large number of cardiovascular disease or cardiovascular events, but you know it's going to take time. So because I'm invested in trying to do this is what I'm doing right now. And my research is now in implementation science, trying to improve CKD detection and treatment in the population. Kind of the phase one of any implementation project is to try to see where are the gaps. So we can devise responsive interventions. And that's what I've been doing for the past year or so. And so the first question that we ask regarding these recommendations, these new guidelines, these new evidence, is what is the real albuminuria testing gap in the United States? And for these, to answer these questions, this was work that was led by Dr. Chu at UCSF. He's a nephrologist at the VA at San Francisco General, I'm sorry. So we use Optum, which is an administrated EHR data set, which includes multiple large US healthcare organizations. And our study population was close to 200,000 patients with type 2 diabetes and hypertension. So what we found is that testing for albuminuria was really low. Less than 50% of people with diabetes were tested for albuminuria. Less than 10% of people with hypertension were tested for albuminuria. But the question that we asked is, if you were to test these people that are undetected, how much albuminuria would you find? And so for that, we use NHANES, and we developed a predictive equation for albuminuria and apply that predictive equation to this Optum data set. And what we find is that a lot of people that we don't test would have albuminuria if we were to test them. In fact, 2/3 of patients with hypertension and type 2 diabetes and albuminuria are undetected due to lack of testing. So right from the start, we know that there's an enormous gap. We're missing out on the patients that would have the major benefit from all these nice new cardiorenal preventive medication. Then I ask a second question, and is in people with CKD, so people that have been tested, what are the prescription patterns of SGLT2 inhibitors and GLP-1 receptor agonists? And to answer that question, I use the VA EHR data, and we created a cohort of around 1.2 million people with type 2 diabetes at the VA. And we asked many different questions, but the most important finding from this paper that we published in Diabetes Care was that opposite of what should be happening, the more albuminuria you have, the less likely you are to be prescribed an SGLT2 inhibitor or a GLP-1 receptor agonist when you adjust for a wide array of demographic, clinical, system characteristics, even GFR. So for people with an SGLT2 inhibitor, you had an albuminuria greater than 300, you had around 11% lower relative odds of being prescribed an SGLT2 inhibitor and around 5% lower relative odds of being prescribed an GLP-1 receptor agonist. So kind of a very large risk to treatment paradox where people at the highest risk who would derive the largest benefit from this medication were less likely to be prescribed these medications. And the last question that I ask is, are there any racial and ethnic disparities in the prescription of these medications? And this is the real reason I use the VA data set to answer this question. And it's because in this field, there is kind of an erroneous tendency to equate racial ethnic disparities with the ability to pay for the medications. And it's because we know that patients of a racial or ethnic minority are on average have a lower income compared to white patients or non-Hispanics. So there's this tendency to just ascribe any difference in the ability to pay. What's important about the VA and doing this work at the VA is that the VA minimizes the influence of medication cost on prescription just because medications are either heavily discounted or they're free for a large proportion of their affiliates. So what we found is that in the VA, Black patients are substantially less likely to be prescribed an SGLT2 inhibitor compared to white patients. And that's taking into account a whole array of demographic factors, provider-level factors, system-level factors, and geographic characteristics. What we found was the lower relative odds of being prescribed an SGLT2 inhibitor of around 30% compared to white patients. Similarly, for GLP-1 receptor agonists, we found around a 40% lower prevalent odds of being prescribed an GLP-1 receptor agonist, again, taking into account a wide array of characteristics. Now, one potential limitation of those results that I showed you was that this was a cross-sectional analysis combining people that had prevalent SGLT2 inhibitors or GLP-1 prescription. So you could argue, well, the developments were relatively new, the guidelines are relatively new, so you're sort of combining people that have long-standing prescriptions with new prescriptions. So it could be that the difference are less in people that have new prescriptions with new recommendations. And what we found here when we looked at insulin prescriptions across a wide timeline was that, yes, prescriptions for these two classes of medications are increasing all racial or ethnic groups, but the gap between white and Black patients stays the same. And this is what we have seen for every single technology that we know has been very effective, is that once the gap between racial groups starts, it is generally maintained. And that we've seen for statin prescriptions, for DOACs, for TAVR. Sami gave grand rounds about, he touched upon racial disparities in TAVR, and we're seeing it for these medications. Now, these findings are aggravated by the fact that diabetes and its complications cluster in racial minorities, in particular in Black patients and Hispanic patients. And we're seeing these disparities in care in a system that tends to minimize these disparities compared to other US health systems. So if anything, this is the ceiling for prescription, and the problem is much worse outside of the VA. So that leads me to say that to get to where we need to be in terms of cardiorenal prevention, we need to do a lot of multimodal implementation interventions. And I'm currently doing this, and this is going to keep me occupied for a few years. And the first and most important thing is to overcome the diagnostic albuminuria gap. So I'm currently working on a digital health intervention where I will be trying to nudge patients into getting testing for albuminuria. That's likely not going to be enough. So I will be at some point trying to figure out if testing for albuminuria at home works. There was a really nice recent paper in the Lancet showing that this is feasible. It's feasible to test for albuminuria at home, and that decreases tremendously the testing gap that we have. We need to overcome the treatment gap and to get the GDMT of primary prevention to the patients that need them the most. I'm working with the APEX team at UCSF in trying to come up with a practice facilitation intervention, and that's a decision support tool. I've learned with this work that it's very hard to get to a decision support tool that physicians will use, something that's actually useful for them, but we're trying to get there. There is some room in this space for innovation in terms of polypros when you're talking about 2 to 3 medications. My research suggests that for any implementation intervention, there must be a racial and ethnic lens to implementation. That sounds like very generic, but there are many things that you can do. So for instance, my digital health intervention is going to send messages in English and in Spanish to try to reach Hispanic patients. But most importantly is to, I think the task is to motivate patients and providers as to the importance of testing and treating CKD for cardiovascular prevention, and that's what I've been trying to do today. So just to close up, CKD detection and treatment is essential for primary cardiovascular risk prevention, and that's both, it is needed for cardiorenal risk stratification, but also for the initiation of disease-modifying cardiorenal preventive treatments. The new cardiokidney metabolic syndrome and framework has profound implications. And I think the correct implementation of that new syndrome and framework could prevent a large deal of cardiovascular complications associated with diabetes and hypertension and CKD. But to get there, we must overcome structural barriers to care, including the low albuminuria testing, these risk to treatment paradoxes, and pervasive structural, racial, and ethnic disparities in care. So I'll stop there, but before I end, this is, if I had to kind of single out every person that has been influential in my career as a researcher or clinician, I would not have space. So I just want to call out my mentors at UCSF, Dr. Estrella and Schlipak. Dr. Estrella is a nephrologist at the San Francisco VA. She's the chief of nephrology there. Dr. Schlipak is a general internist at also the San Francisco VA. And they've been wonderful mentors. If a fellow or a new researcher were to ask me what is the most important determinant of some success in research, I would say supportive mentors, and Dr. Estrella and Schlipak have been wonderful mentors for me. So with that, I will end. Thank you very much for paying attention.